Seeing is believing. As technology has grown exponentially in the past 50 years, at 1970 we were at 5 megabytes, in 2000 we evolved into 5 gigabytes, and presently we are at 5 terabytes. So as the technology has grown exponentially, so has the vitreoretinal surgery. Robert Massimer's original 100 cuts per minute to current day 20,000 cuts per minute. Dual pneumatic actuation and around 20,000 cuts per minute. Reduced acceleration of vitreous contents into the lumen approaches an ideal constant flow. Smaller sphere of influence allows for precise removal of the vitreous for enhanced safety around the detached and highly mobile retina. So this is the case where we are demonstrating a vitreous-based shaving be done in a retinal detachment surgery. The video recording analyzed during an image analyzing software shows the cutter approaching an infinitesimally small distance. The distance measured here is 0.2 millimeter. In this frame, you can now see the cutter has approached to less than 0.19 millimeter to the retina, thus indicating reduced peak tractional forces, less iatrogenic breaks. You can see a PDR surgery being performed here. A near total membrane removal done unimanually with high efficiency and greater speed. This reduces the need for extra instruments and cuts down on the total surgical time. I am doing a membrane segmentation using the cutter and the membrane delamination with the cutter itself. The segmentation is being performed now and then delamination. With a controlled vacuum, you can use the high cut rate. With good control of the vacuum is lesser the iatrogenic breaks. And now you can see 1 week post-op image of this patient. Now this video shows the high precision vitreous removal around the retinal break with minimal fluttering of the retina. Can we identify which has the higher turbulence here, left or the right one? In fact, the parameter shows that the left is 10K and the right is 20K, indicating that both have similar turbulence. Now, looking into the digital filters, we have come now into the digital era. Several current techniques to aid visualization. Dyes that may have adverse clinical consequences, so the use of digital visualization may minimize the adverse effects of dye use via the digital color optimization. This is the case of BBG assisted ILM peeling being done. On shifting to monochrome filter, we can see that ILM is more clearly visualized even at diluted concentration of the BBG dye. You can see how nicely the edges of the ILM is being visualized with the help of these filters, minimizing the trauma to the retina in process of peeling. You can customize the color temperatures also from hot colors to the cool colors for the best visualization. This is the another case with the sub-ILM hemorrhage, and now when we shift to the monochrome, we can see the edges of the ILM being very well delineated so that the peeling process becomes easier. And now flushing out the sub-ILM altered hemorrhage. Now this is another case of PDR with extensive hemorrhage and the membranes. So here when we use the filter called as the reduced red color channel, it actually attenuates the bright red signal of the blood. Thus the membranes look more fluorescent. Dissecting these membranes become more easier with less or reduced iatrogenic breaks. We can use different color temperatures to improve further visualization. In similar surgery, having extensive membranes but with less blood, in these cases the green filter aids in increasing the contrast and proper visualization of tissue plane, which ensures the complete removal of the membranes. Here is another case of PDR where we are injecting a dilute concentration of fluorescein, that is 0.4 ml or 0.4%, consisting of staining the vitreous with diluted fluorescein to enhance its visibility, especially the stroma and the base. Now see how the vitreous is very well delineated. I change the colors to the normal and come back. I change to blue, change to green, change to the monochrome. But the best is the custom fluorescein angiography barrier filter, which is basically a red free and the green free filter. And now I am trying to dissect these membranes with the help of the cutter, flushing out the blood, and now doing a cutter segmentation with low vacuum and high cut rate, and now delaminating these membranes one by one. Fluid air exchange being done, and this is the 1 week post-operative image. Enhanced peripheral visualization, which is possible with the heads-up viewing system. This was a tile cutter presented to our emergency department at 12 in the midnight. A large foreign body with a piece of the tile cutting blade went inside and halved his eye. The foreign body was removed, measuring 14:11, and meticulously suturing was done. And it was taken for the VR surgery after 1 week. I thought it would be difficult to visualize through this small zone of clear cornea, but however, when I started doing the vitrectomy, finding the way through these membranes, a step-by-step vitrectomy was being done. PVD was induced to the extent possible. PFCL was injected to flatten the retina. Retinectomy was done to relieve the anterior PVR, and finally clearing the subretinal hemorrhages. After injecting the PFCL back, we can see a well-settling retina. This is the site for sore eyes. Small zones of clear cornea, which we call it as window of hope. So these are the various cases which we could operate to the small zone of clear cornea. Thank you.